Okay, now that we've done a little bit of an overview of some of the most common and highest yield upper extremity blocks and the principles and some of the generalities around ultrasound guided regional anesthesia, let's go ahead and talk about a few, again, of the high yield, most commonly performed lower extremity blocks. Again, this is not comprehensive. These are just some of the highest yield, most frequently used. And here's a quick overview of just some of the territories of some of the ones that we're going to look at. The first one, the highest yield by far, the one that has probably the best literature base, the one that's most commonly used in emergency departments across the country, is the fascia iliaca compartment block. So you can see the distribution here. The next up is the popliteal or sciatic block, depending on exactly where you do the injection. And you can see the distribution of that here. And then next up is the posterior tibial nerve block, which we do at the ankle to anesthetize most of the bottom of the foot. And again, so if you were asleep, if I knocked you out, wake up for this one, because this one is the highest yield, probably the one that, if you're not already doing this, is probably one of the first ones that you might start doing as a regular part of your practice, the fascia iliaca compartment block. And why? It's been widely adopted. It's been shown to be very safe. One nice thing about this is your needle's not really that close to the actual nerve or the artery. So in theory, maybe your patient can be a little less interactive, although I still think they should be awake and able to interact with you. There's a very strong literature base, and in many emergency departments, this is just a standard thing. If a patient comes in with a hip fracture, they're getting this block. It's being used in our emergency department. It's not quite a protocolized thing yet, but that may be coming down the road. So here's pretty much where the injection goes, and gives you some idea on some of the territory you're covering. So for the most part, you're able to anesthetize the femoral nerve, the obturator nerve, the lateral femoral cutaneous nerve, and somewhat of the accessory obturator nerve. And just again, reminder of the distribution of anesthesia you should expect. This is a nice, easy block. It's great for hip and femur fractures. The most common are the hip fractures that we all see every day. But don't forget to think about it if you have got a large thigh wound that you need to clean out and repair, or a large abscess maybe somewhere on the thigh. And again, because you shouldn't have your needle right up against a nerve or an artery. They don't maybe necessarily, some of these older patients who have hip fractures, sometimes maybe they have some dementia or something else. And in these patients, that's okay, because again, the risk is lower. Just a couple of key tips. Importantly, you want to make sure you stay high enough. You should be right up in the inguinal crease, just millimeters inferior to the inguinal ligament for the most part. This is a large volume block, so depending on what anesthetic you're using, you probably want to dilute it. I personally, most of the time, am using 20 mLs of 0.25% bupivacaine, and I'm diluting that with 20 mLs of sterile water or saline. So I usually have 40 mLs drawn up, and most of the time, in most adults, I inject the whole thing. But we're diluting it to, one, give us a large enough volume, but still not be at a toxic dose. And just I like to have a little algorithm for how I identify these structures and these landmarks. So what I like to do is I make sure I stay high at the inguinal crease and identify the femoral artery, and then I slide laterally and I just follow the fascia that's right over top of the iliacus muscle. This is one of the best videos I've seen on just identifying the landmarks by Dr. Mike Stone.
You're going to see is the femoral artery here, the femoral vein, which will be collapsible and may be obliterated if you've put a lot of pressure on when you start your exam. And then out laterally to that, you've got this hyperechoic triangular structure, which is the femoral nerve. Now, this is your start point, and you'll see the fascia iliaca on top. But this is really just a place to start, because the nerve's going to be just lateral to the artery, and it'll help you kind of get your bearings. So once you start, you're going to go ahead and make sure that you have these structures identified. And as we slide the transducer away from the midline and away from these vital structures, we're going to get a view that looks like this. And once you have this view, you're ready to get started.
So I'll just point out, this is the fascia iliaca here. This is our target. We're going to bring our needle in plane. We're going to get it just under that fascia, and we're going to try, with our injection, we're going to try to peel the fascia off of this iliacus muscle. And here's an example. In this case, we're going from medial to lateral. The femoral artery is over here. Our needle is coming right down through here, and you can see here's the local anesthetic being injected just under that fascia iliaca, peeling it off of that iliacus muscle. There's the needle, fascia. We want to get right underneath of it. There's the fascia. We're peeling it off of that muscle, and that's exactly how we do the injection. Another thing to note, is when you're doing this injection, you should not feel, this should inject very easily. If you're feeling resistance, then you're not in the right spot and you should adjust. Another important one to talk about, this is a little bit more of an emerging application. This is called the pericapsular nerve group block. This is looking as a potential, I don't think the jury's still fully in on this, but this may be a potential alternative to the fascia iliaca block for some other fractures. It may be a little bit better for some of these more proximal injuries, so kind of these more proximal femoral neck fractures, pubic rami fractures. One advantage to this is that it is motor sparing, so some people like it for that. And this is just a little kind of diagram of where you're going and a little bit of how the local anesthetic should spread and what kind of distribution you should get. And the way you do this, you're in a similar area with the transducer, although your injection is going to go deeper. So if we're right near where we would maybe do the fascia iliaca block is probably right about in here. So we're just sliding slightly proximally where we're going to do this injection. And importantly, the landmarks, they look similar, but our target is deeper. So this one we typically would want to use the curvilinear transducer to identify these structures. So you'll see the femoral vein, artery, and nerve here more superficially. This is our target here. We're going to try to bring our needle and get it right underneath this psoas tendon and peel that right off of the bone with our local anesthetic. So we can see a little zoomed in here, nice little cartoon diagram. We're looking for the iliacus muscle and that psoas tendon right down at that inferior edge of the iliacus muscle. We're going to bring the needle in. Here's the needle, and you see we want to deposit the local anesthetic right underneath that muscle, separating the muscle off of the bone. Nice thing about this is you can get the needle down, palpate bone, and then do your injection. Again, it should not have a lot of resistance. You can do the injection right there. Again, an emerging application, may be better for some of the more proximal hip fractures and pubic rami fractures, worth knowing about and thinking about. Let's go ahead and move on and talk a little bit about the popliteal sciatic. Again, with all these things, once you are good at guiding your needle, you can refresh yourself on the anatomy and the distribution and perform pretty much any of these. So let's take a look at this one. So this is the distribution, so more lower leg things. I use this a lot for like a bimal or trimal or some of these nasty ankle fractures that we see. These patients hurt a lot. One thing that's important is a lot of these patients, I'm going to show you what it looks like on the screen and how you do it. Many of these patients, they come in, they're lying on the stretcher. Hopefully they've got their ankle elevated to reduce some of the swelling. They probably aren't going to love you having them flip over in the bed and wobble their ankle around. So there's a couple different ways to do this. You may turn them on their side and approach this kind of superior to inferior, or most of the time when I've done this, I just have their ankle propped up and the probe is inverted underneath in the popliteal fossa, and I'm doing the injection kind of upside down. A nice thing to do if you can find it on your machine is sometimes the machine will let you invert the screen, so that makes it more intuitive. So that's something to think about. One other thing I'll say about this, there's a little fat pad in the popliteal fossa, so really important to get your anesthetic right around the nerve, because if you're not close enough to the nerve, that fat pad will kind of absorb that lipophilic local anesthetic, and it'll probably fail. It won't, nothing bad will happen, you just won't have a successful block. So here's what it's going to look like when you look in the popliteal fossa. Typically, you're going to have a fair amount of compression, so the popliteal vein is going to be compressed. So this is the popliteal artery, and the tibial nerve, which is not technically the sciatic nerve right in the popliteal fossa, but the tibial nerve itself will be superficial and lateral to the popliteal artery. So here's popliteal artery, and here is the tibial nerve. And then as you track the tibial nerve proximally towards the thigh, you'll see where, and let's just pause this for a second. So here's popliteal artery. The vein is collapsed because we're applying some pressure. This is the tibial nerve here. This is the fibular nerve. It's not always, this is a pretty generously sized, so it's even more lateral. That's the fibular nerve. As you track proximally, the fibular nerve and the tibial nerve conjoin together, which is what makes up the sciatic nerve. So what we like to do is track proximally until we're at the sciatic nerve, and that's where we want to do our injection. And the nice thing about that is also it kind of moves you away from the artery and decreases the risk of hitting into that. And here's an example of what that will look like. So we've tracked proximally. Now we can still see a little separation in tibial and fibular nerve, but we're bringing our needle down and we're surrounding, both of those, or if we get the whole sciatic nerve all in one nice bundle, we're trying to surround that completely, but this is what it looks like. Needle comes towards, and you see here we've surrounded that complex with local anesthetic, and just another nice little image of that here. And that should give us that nice distribution, especially for things like ankle fractures. So my little, again, algorithm: find the popliteal artery, look for the tibial nerve, lateral and superficial. Compression often helps visualize the nerve, and sometimes this nerve is visualized best with some fanning of the probe to bring out that anisotropy or reduce anisotropy in the nerve. So compress and work with the probe angle just a little bit to help you identify this. This is a deeper structure. And again, this is going to be a pretty good volume of local anesthetic. Definitely this patient should be monitored for any signs of local toxicity. For this one, I typically do the same mixture that I use for the fascia iliaca block. I'll just take 20 mLs of 0.25% bupivacaine, 20 mLs of sterile water or saline. It doesn't usually take the whole volume in this case, but I make sure I just have that already there and ready to go. And just one more look at identifying the anatomy to help you systematically recognize that nerve and how to find it. So to find the tibial nerve in the popliteal fossa, we just come right to the popliteal fossa, generally find the vessels, and if we compress the vein out of the way, usually the nerve is going to be superficial and lateral, and if we change our angle, we can see a little bit better. And this is just another nice little example demonstrating an actual injection. Here we've gotten a little bit more proximal and identified the sciatic nerve as a singular bundle. And you see we do want to get that needle right on top and right underneath, and we want to surround that sciatic nerve with nice local anesthetic. The last one we'll talk about for today in the lower extremity is the posterior tibial nerve. We do this injection at the ankle, and typically we would do this, maybe there's a large abscess on the bottom of the foot, or I've done this for foreign bodies that have been embedded that I needed to remove, different things. But this is just a nice block that gives you nice anesthesia to most of the sole of the foot for anything that you need to do down there. So you're going to place the transducer laterally, kind of just superior and posterior to the medial malleolus. And you should pretty easily be able to identify the posterior tibial artery, and then the nerve sits usually posterior to that, and there's two adjacent veins that typically are going to be compressed when you're applying any kind of transducer pressure. So again, like always, I have a little algorithm. So distal medial tibia, slide posteriorly, so you're just posterior and superior to the medial malleolus, identify the artery, and then just fan up and down until you see a reasonable target. Here's a little video just demonstrating that. Next, we're going to find the posterior tibial vessels. Externally rotate a little bit. The way I like to find this is higher up above the medial mal, a little bit posterior, and then just slide my way down. And then we can usually identify the artery. If we relax, we can see the veins, and then the nerve sits posteriorly. There's some kind of mnemonic for that. I never remember it. There's the artery. There's nerve. And here's just a nice example. And this is one that I'll often do with an out-of-plane technique. Just bring the needle down adjacent to the nerve, injecting around and beside it, and then trying to get local anesthetic to spread on top of it as well. So you can see here, we're coming down out of plane and trying to get right, pop through that fascia, and then just a little injection that you'll see. There's a little couple air bubbles. Try to get those air bubbles out of your needle. They get in your way. And then that's pretty much all you have to do for that one. Now again, just a reminder, this was just an overview of some of the most common and the highest yield regional anesthetic targets that we think about and maybe use in the emergency department. But there are dozens of others, and this is certainly not comprehensive. There are, abdominal blocks and chest blocks. There are other superficial blocks for neck and the clavicle. Once you have your technique down, once you are skilled at identifying, guiding, following your needle, and injecting around a target, you can incorporate any of these into your practice pretty readily. So get out there, practice them up, get some of the simple ones and easy ones under your belt, and then you can start kind of adding more things into your toolkit. With all that said, let's give a quick just few highlights about some of the summary and key points here. So main things are the POCUS guided regional anesthesia. It's good. It helps patients. There's good evidence that we can decrease opioids, decrease some of the complications related to opioids, and even in some cases that we've shown we can get patients patients on their feet faster, out of the hospital sooner, and that their pain outcomes are better. So good reason to incorporate this as part of your practice and as a multimodal approach to analgesia and pain management. You certainly need to know the contraindications, the complications. You need to know when patients should be monitored, what to be monitoring for, those kind of things. And then again, needle guidance is the fundamental skill. And I say this with a lot of other procedures. If you can learn to guide a needle towards a target and maybe aspirate or do an injection, then you can kind of build on that and incorporate a lot of these procedures, including regional anesthesia, into your toolkit to help you care for patients. And then with the certain blocks, you need to know it's always good, especially if you haven't done whatever block you're considering in a while, to refresh yourself on the distribution of expected anesthesia, the anatomy, and the approach. And again, if you can refresh yourself on that and you are skilled at guiding your needle, this is something you can readily incorporate into your practice. Further emphasis. Needle guidance, fundamental skills. So make sure you feel comfortable with that and you're good at that. And then just quick refreshers, reminders about some of the blocks that we talked about and their distribution. So the interscalene block, good for proximal things, may not get the whole hand. So, great for some of these shoulder and proximal arm things. The supra and the infraclavicular nerve block, sometimes these are known as the spinal of the arm. So they're definitely going to give you pretty good anesthesia to the forearm and the hand, not so much the proximal shoulder and things like that. So keep that in mind. The axillary block is definitely a forearm and hand block, so that's its distribution. And then the one that sometimes we may forget about is what's that innervation of the hand and what part do you really need to anesthetize for whatever procedure that you need to do. And if you need a refresher before you do it, take a look and remind yourself where the ulnar, median, and radial nerves actually innervate on the hand. And then for the lower extremity, we've got our distribution for the fascia iliaca compartment block, our popliteal sciatic block, and then the bottom of the foot for our posterior tibial block. And I think that's everything for today. Again, this is an intro. These are some of the high yield blocks. There are dozens more. If you can guide a needle, you know what the complications and contraindications are and what kind of things you need to monitor for, how to treat complications. And this is something you can incorporate into your practice and with good evidence, help your patients and improve patient care. So thanks a lot. I'll talk to you all soon. Hope to see you practicing in the lab.